The topic of my talk is gallbladder cancer, an accessible biliary cancer, and as I hope to show, that gives us opportunities, but also provides challenges. So the first point to make is gallbladder cancer is the commonest of the extrahepatic biliary cancers, as can be seen from the slide. And you can also see from the slide an important point that it shows a very striking geographical variation in incidence, very common in Chile and India, Eastern Europe, and less common in our part of Europe. And that's important when we interpret some of the studies I'm going to discuss. So as I go through my talk, I want to highlight two things. I want to highlight new topics, and also I want to address the question of how well are we doing gallbladder pathology. So just to remind you of what you know, that there are two routes to gallbladder cancer. There's the metaplasia, dysplasia, carcinoma pathway, the flat pathway, going from chronic inflammation through intestinal and pseudopyloric metaplasia, through low-grade and high-grade dysplasia, ultimately ending in invasive cancer. And there's the less common mass lesion pathway, going from normal mucosa to a mass lesion, either pyloric adenoma or much more frequently an intracholecystic papillary neoplasm before going on to cancer. So I just want to look through what's new in these pathways and what's of greater significance to us. So what's new from the beginning of the pathway is not chronic inflammation that remains unchanged, but a new entity of reflux-associated cholecystopathy. Now I'll show you a slide in a moment, shows diffuse mucosal hyperplasia, and was first described in association with anomalous union of the pancreatobiliary ducts, but has been described now as in other contexts. The important point here is just under a third are associated with gallbladder cancer. So this is an important entity to recognize. Here's a slide from such a case. And what you can see here is the mucosa is thickened. It is complex, and there are lots of downpocketings with numerous Rokitansky-Ashel sinuses. This is really analogous to reflux gastropathy in the stomach. Another new entity described even more recently is foveolar metaplasia stroke dysplasia. The mucosa here is not just the pseudopyloric or intestinal types of metaplasia, but a new type where you get these very foamy surface papillary projections which resemble gastric foveolar epithelium. Now, worryingly, these cells often show dense chromatin from the beginning, which is why it's metaplasia stroke dysplasia, and this also carries an increased risk of malignancy. Now, I need to point out that the literature on this is modest and really would depend at the moment on abstracts, although they are abstracts in very good groups. Here is a slide illustrating these three different types of metaplasia, the pseudopyloric, which often a mass lesion, often predominantly within the wall, intestinal type with columnar epithelial cells and goblet cells. And here we have this new type, this foveolar type. You can see, again, papillary projections, rather foamy cells, mostly exophytic. When we come to precursor lesions, this is a very important paper, a classic paper now, in which it is suggested that the biliary tract and the pancreatic ductal system showed great similarities, and that the nomenclature used for pancreatic neoplasms could be applied to biliary neoplasms in general, and that includes gallbladder, of course. So here's from a MJ Search Path paper from just under 10 years ago, and all these entities share common pathological features as well as common complex, difficult to pronounce names. And we're going to focus very much on the gallbladder variants here. So I'm going to be guided in the nomenclature I use, because the nomenclature has varied since that original description, the WHO classification. And we're just going to go through this. I'm going to start with pyloric gland adenomas. Not a great deal to say. These are relatively common polypoid projections. They show virtually no nuclear atypic, and sometimes quite hard to convince your trainees that they really are adenomas, and I share their perplexity. The only 2 points I want to highlight here are, one, they carry a very low risk of malignant change. Yes, you can get high-grade dysplasia. Yes, you can get cancer, but it's very rare. How rare is hard to say, because nodules or pyloric metaplasia have been called pyloric adenomas in the past. So if you look at papers on pyloric adenomas where they show the histology, very often they're not, in my opinion, not showing adenomas, they're just showing rather florid areas of pyloric metaplasia. And therefore it has been suggested there should be a cutoff size of approximately 0.5 centimeter is what we go for. This is not just one of those kind of meaningless discussions, but if we're going to understand the epidemiology, the natural history, etc., of pyloric adenomas, we need to make sure we really are talking about pyloric adenomas, because if we include pyloric metaplasia, all the risks will be down regulated. Now, onto biliary intraepithelial neoplasia. So the changes here have been to do away with the old bilin 1, 2, and 3 and to replace with low-grade and high-grade dysplasia. This just reflects practice in gastrointestinal pathology through the different areas. It's simpler, it's more reproducible, and it makes pathologists come down on one side of the fence, which is always a good thing to make pathologists do. Now, here's a problem. Here's a gallbladder, which really looks unremarkable, and yet when sections were taken, there was high-grade dysplasia. So this leads us on to the first question about how well are we doing. So here's a paper from the UK looking at the incidence of dysplasia in routinely removed gallbladders, and all these papers have an impressive number of patients. This is at over 4,000, and this found that dysplasia was really quite uncommon. So this begs the question of whether routine histological analysis is required or not. The risks are low, but obviously for those patients who have it, it may be very significant. So let's start to think about this a little more. When you find low-grade or high-grade dysplasia, or maybe just some atypia and you're not sure of the significance, pathologists want to go back and take more blocks. And in this paper from 2012, they reviewed the suggestion, which was current at the time, that you needed to block the whole gallbladder. That's quite a lot of work. Gallbladder is not a massive organ, but you'll end up taking quite a lot of blocks and taking up a lot of the lab's time, a lot of pathologist's time. And they did, I think, quite an elegant study and suggested that just 4 additional slides, I emphasize the word slides, were adequate, and that was encouraging. That hasn't been reflected in the literature really since then, I have to say. This is from a very recent recommendations from a histopathology paper from some of the best gallbladder pathologists in the world. And this is their recommendations. Well, the first 2 are pretty similar, 4 blocks or 4 to 6 extra blocks. But for high-grade dysplasia, they recommend blocking the entire gallbladder. Why do they say that? The answer is something like this. With high-grade dysplasia, it's normally quite diffuse. So if you find low-grade dysplasia and you're trying to exclude high-grade dysplasia, you don't need many extra blocks to do that, because it's normally very extensive and will be found relatively easier. With high-grade dysplasia, you're trying to exclude invasive cancer. Now, that can be focal, and although it has to be said there's normally early gallbladder cancers associated with high-grade dysplasia in the context of no mass lesion, it can be T2, we'll talk about that in a moment, and therefore you need to submit much more tissue. And I think these are practical guidelines and really pretty much, I have to be honest, reflect my own practice. Now we go on to the more challengingly named intracholecystic papillary neoplasm. As I said, all these lesions have had a number of other names in the past. I just want to again highlight some points. Now, in some studies, up to 50% are associated with cancer. So if you see them, you need to take lots of blocks. Turning it the other way around, 6% of carcinomas are associated with intracholecystic papillary neoplasms. When we look at the 5-year survival, we see some interesting things. For non-invasive cancers, it's 80%, which actually in some ways seems surprisingly low, and I'll try and explain that in a moment. Those with invasive cancer, it's 60%. And here's a very important point. If you have a gallbladder cancer, if there is associated ICPN, the prognosis is better than when there's no associated lesion. And therefore, it's very important the pathologist just identifies ICPN and records that in their reports. Why is the prognosis not better for cases which are benign and are totally excluded? It's because these patients have increased risk of biliary cancers in other parts of the biliary tree, and these may be seen sometime later. So that's an important point to raise here, that there may be a field change. And here's a picture of one. Here's a papillary lesion, but you can almost see breaking off. You can see it even here in a microscopic section, quite a narrow stalk and knocked a little bit. So often when you open these, a lot of it has just fallen off into the luminal gallbladder, and if you wash them away, you won't see anything at all. So you have to be rather cautious when you open these lesions. Here's a new lesion described last year of mural intracholecystic neoplasms. These arise in adenomyomatous nodules. Now, is this just another example of pathologists wanting to subdivide things? Well, it may well be, but there are some practical consequences. First of all, there's no field change with these lesions, whereas ICPNs of the normal type are multifocal in 1/3 of cases. So again, you need to go take lots of blocks to exclude them. Only 16% of these show malignant change. I've already told you that the ordinary ICPNs show 50%. And it's been suggested these are analogous to the pancreatic intraductal papillary mucinous neoplasms. These are uncommon, but when you see them, you need to recognize them, and they have particular consequences of their own. Here's a histological section. Here's the lumen. Here's the cut wall, and you can see this nodule on the wall, and a rather pretty low-power image here showing intramural papillary areas. Now we're on to carcinoma of the gallbladder itself. We've finally got there. So here is the current staging system, and I want to address a number of points in the staging system. First of all, the distinction of T1A, in which tumors are confined to lamina propria, and T1B, which is tumors muscularis, is very difficult. We all know the gallbladder only has one muscular layer, but that muscular layer is itself very poorly defined, and therefore it's very hard to know when a tumor is coming into the muscle because it's got a rather irregular interface. Also, it's very hard to know when it's coming out of the muscle because that's also rather irregular. So it's been suggested as a practical approach to combine in situ, lamina propria, and just into muscle cases as early gallbladder cancer. That makes good sense. These patients do well with simple cholecystectomy. However, if you see them, you need to block the whole gallbladder. Here's a recurrent theme, because you need to exclude something deeper going on. T2 tumors are, of course, the next stage up. This is through the muscle layer, but again, these also need to be subdivided. And again, I would suggest, and I would obviously always be happy to hear other people's views, need to take a lot more blocks. So the staging is important, and the pathologist plays obviously a critical role in that. And we look at the prognostic factors for gallbladder cancer in general. The extent of the cancer is important, involvement of Rokitansky-Ashur sinus is important, involvement of cystic duct margin is important. And for T2 cancers, the extent of invasion of this at T2A, just into connective tissue around the liver, T2B actually into the liver, and very important, whether the tumor is involving the serosal surface or the hepatic bed. To illustrate this, I want to show you two slides. Here's a slide comparing involvement of the when Rokitansky-Ashur sinuses are involved and when they are not involved. And you can see there's a very significant difference in prognosis. And this is something which needs to be recorded, and to be fair, this is not always done. Now, involvement, but tumor location, I think is extremely interesting. You see here that if the peritoneal surface is involved, the prognosis is much better than when the hepatic surface is involved. Slightly curiously to me, if both the hepatic and peritoneal surface involved, I'd have thought they would behave like the worst of the two and would parallel the hepatic involvement. But in fact, starts off following the peritoneal one and then later on joins the hepatic one. But clearly, the very important prognostic information that the pathologist must provide to the clinician. Now, there's a very good recent review from the Edinburgh group and Journal of British Surgery, which pointed out that the majority of gallbladder cancers are found incidentally, and that the frequency always depends on the area you're coming from, less than 1% in the West, 2% and maybe more in endemic areas. So this opens another question. If you have a gallbladder in which you know mass lesion is suspected, is it enough that either the surgeon or the pathologist just looks at them macroscopically and saves the pathologist a lot of time and effort in taking extra blocks? So this is a Swedish paper which took an interesting approach. They examined a number of hospitals, those which took a lot of or all of the gallbladders were sent for pathology, and a number in which either they weren't sent or only a very small percentage were sent. And they found, perhaps it's not a great shock, that those hospitals submitting more than 3/4 or even all their gallbladders found more intraoperative gallbladder cancers than those that did not, with a reasonably high p-value. And therefore, it's quite clear that sending gallbladders for pathology will result in more gallbladder cancers being picked up. Right, there's a very big literature in this area, and I am not intending to review it now. I just want to illustrate two studies, one from Chile, which now, let me tell you, having worked with Chilean pathologists, these guys really know how to find gallbladder cancers, and yet they missed about a third by just macroscopic observation, and very similar figures from Nepal. I do rather like the curiosity that one had 669 cases and one had 668 cases, but we can pass on from that. Now, we've been doing an audit in our department of how well gallbladder pathology is done with reference to those cases referred to us from non-specialist centers. Now, for sure here, I am not attempting to criticize other centers. We are specialists, therefore we only look at one thing, and it's much easier for us. But nevertheless, I think there are some important conclusions. So the French study was a multi-center study done some time back, and they found a number of interesting conclusions. First one was that 29% of cases only stated the TNM stage at the end of the report, which is a kind of a fundamental thing to have, whereas we found something similar, but 36%. We've only looked at 25 cases so far in our audit. The actual critical points, the T stage, the involvement of the margins, and where the tumor is, in their study was only reported in 30%, and ours 44%. So there are differences between them and us. But what is clear, that not all the information that should be recorded is recorded. Now, these are the particular features that they studied, and in red are our figures, and as you look through it, you'll see our figures are, broadly very similar. The real point I want to highlight here is the points that are actually literally highlighted in yellow. The exact size of the tumor, which we've already discussed, is an important factor. The surgical margins, the lymph node status, and the distance from the cystic duct. Because these are features that can only be identified when the specimen is cut up. When we receive the referral slides, we can no longer address these questions, and therefore what we say will be limited. Now, it's a challenge for the referring pathologists because they didn't notice cancer before they took the blocks, but they need to go back and assess these things the best they can. When we looked at our comparison, when we stage cases over the original staging, you'll see that we slightly tend to upgrade cases on our review. I've already suggested this can be difficult, the distinction between T1 and T2, and therefore, but broadly similar. So it looks as though this T stage is about right, but there is a hidden problem here. Have enough blocks been taken to be certain about this? So again, this is from the recent histopath review, when they suggested that if you see in carcinoma in situ, T1 or microscopic T2 tumors, you need to submit the entire gallbladder to be sure of the staging. What actually happened? Well, in these cases, we found that instead of submitting entire gallbladder, additional blocks were frequently taken. There was a range of 3 to 8, but with a median of 4. Now, I'm telling you, to block out a gallbladder would take, 10, 15, maybe even more blocks, or depending on how many pieces of tissue stick in the cassette. So in my opinion, we are understaging these gallbladder cancers because we are not looking hard enough for them. Now, again, nothing can be done once they're sent for review, and this is an important role for college and for others to encourage people with these relatively uncommon but not exceptional cases to go ahead and take an adequate number of blocks, or to submit the tissue to the referring center, the center to whom they refer. So coming into conclusion, what's new? Well, there are new entities. We talked about reflux-associated gastropathy. We talked about foveolar metaplasia. We talked about intramural intracholecystic papillary neoplasms. We talked about new prognostic factors. I highlighted hepatic and peritoneal involvement. I have not talked at all about immunohistochemical markers. That will be a topic for another day. And then the important question, how well are we doing? Well, I think we need a better evidence base, one that's relevant to practice in this country. How many extra blocks do we need to take for dysplasia? How many extra blocks do we need for early cancer? So although we know a lot, there's a lot more we need to do. Thank you very much.